Okay.
Good to see
Perfect.
Hiskios on the line as well. Hi, Hiskios.
Hello, hi there. Hello.
Hey, good to see you.
Good to see you. Nice to meet you.
So, how did you have any introduction, or just shall I dive into it?
Yeah, I think, well, thanks everyone for being here. You know, really, this is the fourth case discussion that we've had with Dr. Mengistu and Hawassa University. And really what this case conference has, we meant to do with it is to really highlight the cases that Dr. Mengistu is seeing at Hawassa. Last month we had a case conference that's a little bit different, where our fellows from UC Irvine presented cases for cervical trauma. And we had a discussion with the trainees at Hawassa. And this month we'll have a really special case discussion for operative cases at Hawassa, but that need surgery, but can't get surgery right now because of a lack of implants. So really excited to see, you know, ways that we could help, you know, these patients and improve the care moving forward.
Yeah. So thank you very much. So today we proceed with the cases that we see here, but we are not able to operate them. Who deserves the operating management? So I will pass through this one again. I will try to since it is 1 year since we start the spine service in our center. I mean, once I return back from Ganga, so I will show you the 1 year case mix that we are getting here, opportunity and challenges, and the way forward in both service, academia, and research. So spine surgery service in Hawassa, it starts in July. Just we celebrate 1 year, so it was not really fruitful as I was thinking. When we started, it was started just by looking patient at OPD and non-operating management for trauma cases. Operating management for those who deserve operation was started at the end of November, since we were not having implant. So the big bottleneck was the lack of implant and lack of instrument to give operative service. So this all operating management, I mean, was happened due to the great help from Hawassa University and AO Alliance, especially AO Alliance. They give a lot of help for us. Specifically, they pay for 3 sets: a CDF set, lateral mass screw set, and thoracolumbar set, all from India. And they also spend 25,000 USD to buy different types of implant for cervical spine as well as thoracolumbar spine. So still now, we are using the implants that we get from this donation. A total of 43,000 USD set and implant were offered for us. And our university was also buy some consumables, plus they bought also one decompression set and thoracolumbar set. So now we have 1 ACDF and 1 lateral mass screw set and 2 thoracolumbar set with additional 2 decompression set in our center. So this all were really critical to start operating management, and we're having the pleasure to use this all. When we come to the case mix for the last 1 year, the most common case that we see is degenerative. And the good thing about degenerative, you can put the patient on different type of analgesia and supportive care for non-operative treatment, even though they need some kind of operative intervention. And most of the degenerative case, either they need decompression or discectomy. So that was a good thing. We were able to manage that one in that aspect, since we were having it doesn't require a special type of implants. That's a good thing. But we have also cases who need operating management, like spondylolisthesis or multi-level degenerative disease, which needs multi-level decompression and stabilization. But so we are putting them on the waiting list, since we don't have appropriate implant. The next big case mix was from trauma. Actually, most of the trauma patients that presented to our center presented late or delayed a little bit. because they are referral cases. They will be seen in nearby hospital or healthcare facility, any type of healthcare facility, a private center. Then later on, they will be referred to our center for operative services. So bone trauma patients, most of them who arrived to our emergency OPD will need a kind of operative management. That is one of the headache for us. Deformities, they are really few. They are not a lot, only 25 cases. And we have patients with TB spine. Some of them who require surgical intervention, and others just they can be managed with chemotherapy. We get a few number of cases with malignancy. Probably since we are not operating such type of malignancy cases, that's why we get less number, or they may be operated in another center. I don't know. I mean, so the overall the case mix look like this one. Mostly we are facing degenerative spine. We have one-day clinic, almost it is for degenerative spine cases, it seems, and we are getting the trauma cases to our emergency OPD. So how is the service provided? The big bottleneck, as I try to mention, is lack of implant. So, and the implant cost is really, really high. I will present, I have one slide on this actually. So the way we cope up this bottleneck is like we are using this either of the three strategies. One, patient who can match or pay fund for implant, we request them if they can afford at least half of the implant. For example, if I need 8 spherical screw, we will request them if they can afford buy 4. Those who can afford, they will buy half of it. That is what we call matching. The other thing, those patients who have a community-based insurance, there is an insurance system in the community where they pay very few money per year, and they will get a service in the government institution. It is not like another insurance where every medical cost will be covered. Here, yes, the service that is given in the government institution will be covered by this insurance. So if they brought this community insurance paper, so that is approved by the university, university hospital gives the service for free. So we operate them for free. So that's not good for us actually, because our implant will be, I mean, that patient will get operated with our implant, then we will not have another substitute for it. The third point, there are some patients who came from NGOs or organization who can pay for them, or institution who can pay for them. Either it is phase-based or other type of organization. If they can buy the whole implant, we will share and give to them, and they will buy and will operate the patient by their own implant. So this is the strategy that we are using in order to cope up with the lack of implants that we are facing. Some cases will be lucky enough, they will come early. So for example, this guy, he came with L3 breast fracture with HGOC neurology. He presented to us after he had catheterized for urinary retention plus. His power in the direction was 3 out of 5. So as you see in the axial cut as well, he has a significant question who compromised the canal. So he was having the community-based insurance. We take him to OR and we do decompression and stabilization. Now his neurology is back and he's doing good. These are also another lucky patient. This is another lucky patient who was having post-TB deformity with AGA neurology. He can't afford actually to buy any implant or too much. So the only thing that's the options that we have, since he has AGI neurology, we need to decompress it and give stabilization. Initially, my thinking was just to do decompression, but once I get in the OR, it is completely unstable, and I do stabilization with our own implants that we get from the donation. So these are a kind of just an iceberg of the patient who are lucky enough and operate with our own implant. So regarding the opportunities that we have in Hawassa University, one is the international collaborators like this team, and the fact that we have Alliance, they are really supportive in donation of some implants, specifically for the last years. We have good CR, which is working, and the availability of digital X-rays, scan MRI can be considered as an opportunity for me. At least it is, it makes things easy to investigate the patient and to give the service. The big challenge is, I also tried to mention before, patient presented with the referral, so there will be a delay in the inter-facility referral system. That's a big challenge for us. We have patients for whom we give operation after 6 weeks of presentation. I mean, after 6 weeks of the trauma, they present late to us, then we need to process for the implant and the like. That's another big challenge. The second will be most of our patients, they can't afford for implant and buying material. So I was just doing this kind of scouting review of the previously operated cases. More than 80% of them, they can't afford at all. So this patient should be covered by any means since they deserve the operation. Big bottleneck is this one, the implant. For example, this patient, he has, as you see, 4 screws on each side to about below, and we use 1 rod. To do this, the implant cost for this 8 screw and 1 connecting rod is this much. As with the current price, if somebody wants to have this type of operations, they need to pay more than 1,862 USD. So which is really, really expensive for any Ethiopian civil servant or any or Ethiopia. It's not really cheap. You can imagine if we want to construct a long segment like 3 above and 3 below, you can imagine how the cost will be going high. So that is big bottleneck. So now I'm going to directly to the some of selected cases that need operative management for their spine issues that we didn't operate yet due to lack of implant. So the first patient is this 52 years old female patient. She sustained trauma and presented to us with C2, C3 facet dislocation with HGOC neurology. So we're discussing with the patient as she needs reduction and operative stabilization. The plan that I have was like to do either C2, C3 stabilization, or based on the interop finding, we can also go up C1, C2, C3 stabilization. I prefer to do posterior operating management because a little bit the cost is low for the implant compared with that of the cage, and it is high up since I don't have appropriate retractor for a CDF. It will not be easy for me. So that's why I was planning to operate from the posterior. But meanwhile, the patient can't afford to buy anything. So they left the hospital against medical advice. I know the neurology is incomplete. If we operate this patient, she gets a lot of benefit for sure. But finally, it doesn't happen at all. So this is one of our patients. The next is also C-spine injury again. This is lower C-spine injury, C5, C6 facet dislocation with AGI neurology. In one side, the facet is punctured, and the other side it is dislocated. So this patient, my plan was to do ACDF because it is mid, it is easy, it will not be difficult. Once we get the cage, it is a kind of operation that we can offer for the patient and rehabilitate them. But finally, again, this patient was not able to afford to buy anything, and we don't have cage at all. So the patient is discharged with neck collapse. So these are really painful scenarios. That if, for example, this patient has AGI neurology, unless we operate and make them to ambulate, like it will be bedridden, and she needs like somebody support even to take her from bed to chair. So that means for Ethiopian population, it is not easy. I mean, most of them either they will have daily work to make money, or they are civil servant or something. We can't hire somebody to take care of this patient, or we can't take the patient to rehabilitation center. Of course, we don't have at all a rehabilitation center for spine injury cases. Even there are some rehabilitation centers, social rehabilitation centers, it will not be possible to afford again. So giving operation for such type of patient will be like, it is significantly helping their future. But again, it doesn't happen. Third case is the thoracic injury patient. This is a 44 years old male patient. He is presented with this CT scan. As you see, he has T3, T4 aortic C injury, terrible injury, complete translation with AGI neurology. Similar to the other AGI neurology, this patient will be also get benefited if we reduce it back. By this, the spinous process was just painting the skin. I mean, it is significantly displaced. So if we do a reduction in the posterior instrumental stabilization, again, even though it doesn't change the neurology, the lower extremity and bowel and bladder function, this patient can be wheelchair based, and he can by himself mobilize from place to place based on the wheelchair. So, but again, they can't afford they can't afford. And you can see on the axial view how the two vertebral body appears parallel due to the significant 100% transition due to the high energy trauma. Another case is this one. We are getting terrible trauma. I don't know why. It could be due to the high energy from fall from height, like tree or the building, as well. We are also really prone for motor vehicle accident. So this is another patient who sustained fall from height, and as you can see, he has T67 A-types injury with AGA. Part of C7 is completely retropulsed posteriorly, and it is seated on the cord, and it is one of the terrible traumas, seriously. And on the MRI as well, the nerve is completely blocked by the bone. So this type of case, they need to have at least urgent operation, and we need to compress the nerve, whether it is returned back or not. But again, it is impossible to do that one again. So this is out of trauma. The fifth case is a patient, 20 years old female patient, who is present to us with lower extremity weakness and progressive deformity in the back. So from the MRI, it seems like it is high likely to be TB, because it is we can see the abscess collection, the epidural space as well as paraspinal space, and the deformity, everything will go for TB. So the plan was, since it is EGA, again, we need to do decompression, take biopsy, reduce it, and give a posterior stabilization, instrument stabilization. Of course, TB patients, they are really miraculous. They respond significantly for chemotherapy, but if they have neurology deficits, that is an absolute indication to do compression, posterior instrumental stabilization, and take biopsy for confirmation of the pathology. But the patient can't afford, and we can't also use implants that we have, then they go back home with chemotherapy only. So similarly, this is a post-TB deformity case with EGAB neurology. You can see how big abscess in the first MRI in the left side. You can see how there is a big abscess in the paraspinal space. So this is like it looks like a baby. So this is the kind of patients that we need. If we give operative management for them, we will significantly decompress the compression over the nerve, and the rehabilitation, the response to chemotherapy will be significantly improved. Again, it is impossible for our patients. So there are some cases which are really difficult that we get. This is one of a high school student. She is 15 years old. She has significant deformity, as you see from 3D. I used to put the X-ray and other CT scan, but it doesn't show clearly the deformity. You can see in the thoracic how the collapsed vertebra is there. Of course, I'm not doing such type of operation. Technically, I feel like I'm not comfortable. We don't have neuromonitoring, intraoperative neuromonitoring. Plus, this kind of patients, they need to have vertebrectomy, so vertebral resection osteotomy. So I don't feel I'm good on that. Just I guess this patient, but I advise her if she can go somewhere, leave alone to go somewhere. She can't afford to come even for next follow-up. I don't know why such type of deformity, trauma, and the like. It is a disease of poor. So where I have this patient as well on the waiting list, where we will call to her when you come. That's my plan. But there are some kind of deformity that we can do in our center. This is one of the patient. She is a 4 years old female, young child. She was having treatment for TB. She's treated for TB with her mother. Her mother was having TB, and the child was also symptomatic. They treated her, and finally, even though she get treated, she ended up with this deformity, and it is really painful for her. She can't walk, she can't sit or sleep. It is really painful. So for such type of patient, at least with what we have at hand, we can operate her, and I feel like we can improve. At least we can improve the pain that she is suffering from. But again, we don't have appropriate implants, and we are not able to offer the treatment. So all in all, these are just selected cases from each division. I try to select the representative case, like from trauma, from TB, and deformity. Otherwise, we have a lot of cases who are on the waiting list as well. Trauma patient even who are discharged back home with advice and non-operative option. So what is next? The next is what we are doing now. I feel like we need to work hard in hunting for resource mobilization with implant and rehabilitation. Again, we need to work on the educational aspects, like with this monthly case discussion and further training, specifically on deformity and others. I don't know, Kiran, he raised his hand. Should he forward this question or once I finish it?
Please finish, Mengistu. Just wanted to say that I had a
Okay, thank you very much. So we need to work on the service, specifically resource mobilization. We need to get implant by anyways, by influencing the government. I don't think it will be possible for the short run, or searching for collaborators who can help us. That is one thing. The same for the rehabilitation. Even those patients who have AGIA and we give operative management, they presented to us with DVT, newly developed DVT, once they get discharged, even though they are on aspirin or actually they can't afford the low molecular weight heparin. We put most of the patient on aspirin. They develop DVT plus. They have also pressure sore, sacral pressure sore or other side. So in order to reduce this thing, we need to have a kind of rehabilitation protocol where we can help these patients. That is the other thing to work. Education, yeah, clearly such type of educational opportunities should be advocated, and we need to use that to the maximum. Like the previous last month, we discussed a lot about cervical spine injury, which is really helpful for myself as well as for my residents. That's a good thing. Further training on specific pathology will be also key, like for example, to manage deformity. Further training, shorter training, like which will be important. It could be the expert can come to Hawassa, and we all the staff, including the nurse, anesthesia team, the surgeon, and the resident can get training. That will be, I feel like that is really cost effective. And the other way, we may need to have also some short-term other measures. That will be key. Research, we have these 3 points to be done for the coming couple of months and 2025 coming years. So one of the study which then on spine will be outcome of thoracolumbar fracture. This will be a study in collaboration with the Science Spine team. We are having a Zoom call just a couple of days back. So it will be a multi-regional study in Kenya, Tanzania, here, Malawi, and other places as well. So we are part of that. We are glad to be part of it. It will have a significant role in different aspects. The other thing, we are interested to see the pattern and outcome of previously managed spine trauma patient, both operative and non-operative. Specifically on the pattern, we are really interested. Most of the patients who have AGIA injury, mostly, I should say, I didn't count, but I should say more than 75% of them, they presented after they sustained fall down accident from either tree or building. So this is something that we need to alarm the community and prevent. Once they develop AGIA, whatever we do will not change the neurology. So it will be like a lifelong disability will be there. So our plan is just let us see, like we have nearly more than 100 or something trauma patients. We need to review all the documentation, and we need to identify and work with the respective stakeholders on this aspect, how we can prevent such type of trauma and permanent disability. The other is whenever we do the operative management, we measure the thoracolumbar medical dimension. It is completely different from what we know from textbook or articles. It's not the same with Asian population or other, I feel. I mean, from the articles, dimensions, the diameter is wide, really. The length is in some areas where we need, for example, for lumbar area, in some patients it is really short. So I want to see at least the representative pedicle dimension study for Ethiopian population. So we need to redefine it. I mean, I don't think what we know from literature and the book is working for our population. So that is another study. So we will use the whole body CT scan that is, for example, taken for C-spine injury. We can measure the normal pedicle on the whole spine CT scan, and we can see how it is different from the others. So finally, this is the summary. I put here 2 different pictures, the first and the last. The first is all the individuals, they bring their hand and they're saying that like we are together versus second one, there is somebody who are digging outside, like that of first author, and the others are there doing their own business, talking, chatting, something. So if someone is working and the other is just observing, it doesn't bring a change. That means it doesn't bring any long-term impact. If we want to bring long-term impact, we need to work together. In the other way, collaboration will be key. That's what I want to say. And I feel like my life motto is like this one, which is in my email actually. If we can work together, we can achieve more. So teamwork is really a big thing. Collaboration will be key. There may be somewhere where we will get excess implants, but we are not getting it. It may be easy to get implants in Europe or in US, but it's not easy for a low middle income country like Ethiopia. So if we bridge this one, I hope we'll help a lot of poor patients, and that is the whole what we left behind. So after saying this one, I would say thank you very much.
Thank you so much for sharing that. Karen, I know you had your hand up.
Thanks. Yeah, I mean, let me put my hand down. As a non-spine surgeon, take anything I say with a grain of salt. Mengistu, incredible complexity of the cases that you just presented. Multi-segment disease. You know, these are cases that in our setting we would be doing with neuromonitoring. We would have ICU available, that sort of thing. I mean, it's much more than just an implant issue. It's like a whole capacity issue at the facility level. Have you given that any thought? I mean, there must be a line that you will have to draw. Even if you do have the implants available, the facilities will limit the kind of cases that you can tackle. Have you given any thought to that?
Yes, Kiran. You are right. Absolutely. I mean, spine is really, it's not like even orthopedics. I'm orthopedic surgeon. At least I operate for long one, upper or lower extremity, and the rehabilitation can be done with orthopedic surgeon or resident or the staff that we have. Spine is not like that. Operation is not the end. I mean, it is the process. I mean, even we operate the patient, it doesn't mean like they will have a good outcome. So all things will be depending on the rehabilitation. Rehabilitation, the other way, it is really expensive. Even it is more than expensive than that of the surgery. So there are some things that we can do in our hand. There are some things that we can't do with what we have. So for example, we are planning to prepare instruction, post-operative or post-trauma rehabilitation kind of flare, which will be given for the patient in their own language. And it will be augmented with that of some picture also. For example, the family, how the patient, they need to mobilize the patient for lower extremity mobilization to prevent DVT, how they need to reposition the patient every hour to prevent pressures or anything like that. This is something easy. We can teach the community, and I mean the patient family, and we can give that printed sheets to them to use whenever they want. Plus for EGIA, what we are doing, and still we didn't resolve actually. We submit a short proposal summary to get wheelchair. All patients with EGIA, they should be discharged with wheelchair. Whatever you do in the government institution, either hospital, CO, or Federal Ministry of Health, you can't get any wheelchair for such type of patient. They can't offer for at all. Even just to shift patient from one place to other, it is not easy. So what we plan, and actually we are trying to get couple of it actually, is we write a short proposal for individuals who can help on this aspect, and we are having backend for the communication. So whenever we operate patient with EGIA, we will discharge them with wheelchair, so that at least they will use their own upper extremity and can mobilize from place. These are some things that we can do in our hand. We have also good communication with our physiotherapy team, so they will come to work and do some exercise for our patients, even though it is not sustained. You need to call every time, like I have a spine patient, please come and visit the patient, do this thing. Even though we are on that stack, but it is a good start, I feel. Otherwise, yeah, most of the things, they are resource demanding. Like for example, neuromonitoring, it is resource demanding, and somebody should be trained as well. In our country, I should say, in most low and middle income country, acquiring of some big what can I say, instrument or something is not difficult. For example, we have the state-of-art MRI and CT scan, but the big issue is the maintenance. Once it is go down, you'll be out of CT or MRI for long months, like 6 months up to 1 year. So that is terrible. So even we get, for example, a neuro monitoring, unless I have somebody who gets trained and takes the responsibility, it will not be easy. So in general, Kiran, to address your question, there are some things that we can do. There are a lot of things that we can't do. But by imagining what we can't do, we should not stop. I mean, we need to work, we need to struggle, and the likes. That is what I am thinking, Kiran.
Yeah, no, I agree. I mean, from the cases you presented, I mean, the lowest hanging fruit seemed to be obviously trauma and pot spine. I think these congenital cases with like hemivertebrae and like fixed deformities, and where you're planning on doing like big corrections that could potentially lead to, you know, loss of signal, and you need neuromonitoring for that sort of thing. I don't know how Dira and Hao-Hua feel about it, but I sort of would imagine like a stepwise progression of increasing the facilities and capabilities in Hawassa, and hitting the low hanging fruit first, these like multi-level fusions for trauma or for pot spine. Like, just to share a quick story for maybe some of the trainees on the line, there's a story from Malawi that has become sort of a cautionary tale of a visiting surgeon from America, who I don't know who this person is, but went to Malawi and performed like large, you know, scoliosis cases, multiple levels, you know, and a young kid from a rural area was paralyzed after one of the surgeries. And the parents refused to take the patient home because they said the patient walked in with perfect function of their legs. We're not going to take the patient home if they're not walking. So the hospital sort of inherited this patient and had to figure out, you know, how to house and school and clothe and feed this person for the rest of this patient's life, because they came from an indigent background. And devastating for the patient, devastating for the family, really, really difficult for the hospital to deal with. So I think that there's a lot of danger that can be, you know, seen from pushing the limits in the setting, you know, so like without neuromonitoring and ICU, tackling these congenital scoliosis cases, these fixed deformity cases, things like that, you know, really tough. But I think that there's so much that you can do with, like, already, if you were to have the implants, of course, like the appropriate implants to be able to perform multi-level fusions. Anyway, that's just my impression. I don't know if Mengistu, you have any comments on that, or Dira and Hao-Hua.
Yeah, I think that's thanks so much for bringing that up, and thanks again, Mengistu, for presenting all those cases. They're actually very insightful into the patient population that you're treating. You know, from what you have shown, even just from the brief case mix, you know, you have a lot of trauma, spinal cord injuries, both cervical, thoracic, thoracolumbar. There are cases that you talked about that were deformity, cases that were pretty interesting also from a TB perspective. I definitely see that, you know, that's a very unfortunate outcome for that patient that was in Malawi. And definitely that's not something that anyone would want. I do think that there is value for treating those patients, because I think at least half the patients you presented, Mengistu, already had weakness. You know, there were like Asia C, Asia B, Asia A, especially for those incomplete spinal cord injuries where they're already paraplegic. I think those are the patients that would perhaps benefit the most from trialing an intervention. You know, they're not the case of a kiddo walking in with full function with any risk of paralysis. These are patients that already have some neurodeficits. So in my mind, those would be the ideal patients to try and help, you know, if we were to get some additional implants.
Mengistu, amazing job presenting it. So have on the line, and agree with Karen and Hao-Hua. The one thing you know, that might make sense in terms of planning these cases is, although there's a good case mix, I agree with Hao-Hua about especially the cervical trauma, because cervical trauma, especially in the cases you showed bilateral perched facets, in that patient, if you can get them reduced in a stable way, and especially if you get to them early versus if you get to them late, you may obviously prevent them from having progressive neurologic decline. And as you know, the cervical spine, if you can prevent a neurologic compromise there, then you can save a huge amount of their quality of life. Whereas if they have a functional decline because of the neurologic deficits, I mean, that's a life-altering pathway that could have been prevented. The other thing to think about with the cervical spinal trauma is that if it's a patient that has a perch facet and gets to you at a reasonable timing, like you showed in the lower cervical facet injury, you can do an ACDF and most likely it'll be stable enough. But then as you think about these more chronically or subacute, an ACDF actually may not even hold enough because the posterior tension band is so disrupted that they're going to fail an anterior only construct. And so maybe it makes sense to think about protocols. And I think the protocols might be worthwhile, like the short segment instrumentation you did in the thoracolumbar spine. That's a beautiful, I think, approach to this. It's very cost effective, it's implant effective, and it gets everything very, very predictably done for the patient. I think in the cervical spine, you have the same opportunity to think about timing, level of injury, neurologic deficits versus not. And then you can make a pathway for these patients. And then on the deformity side, I totally agree. Those are huge, huge whacks. And they need a lot of buy-in from the patient and their families. Like those I think you have to do a lot of beforehand education before we tackle it. So it makes sense to potentially do it when the whole team is there and can provide services, and we can learn as a group. But especially before that, the patient and family needs to be really educated about the options.
Yeah, absolutely. Thank you very much. I agree with all the points that raised. Yeah, of course, we are doing some simple cases. When we start doing, we didn't start from complex case because it is terrible. First of all, I should not have like the thinking I made wrong for the patient. So in order to get that, I should disclose. I mean, we start from some simple case, even for the trauma. Then, of course, with time, I feel like we need to proceed with the other patients as well, not the deformity. Deformity is completely different entity. Still now, I never operate any deformity case, except simple deformity for the spine, TV spine case. Otherwise, we didn't do a lot on that aspect. Yeah, everything, whenever you try to do something, it will have some complication. Like surgery, as you all know, surgery is like driving in the road, right? Whenever we drive in the road, we could have any road traffic accident. We are not immune. Similarly, whenever we operate, whether it is, I mean, whether it is simple or actually in spine, there is no simple surgery, whether it is kind of minor or big surgery, it could end up with a lot of complication. Like we face durality. I was having a really difficulty to reduce translated spine. So this all will be the anticipated complication. And of course, I'm working to discuss with the families before we operate the patient what can attest a major complication. We are disclosing to the patient and working in that line. So thank you very much for all points that is. Yeah, please.
I see, Dira, you have your hand up.
Yes.
Yeah, thanks, Hao-Hua. Thanks, Mengistu, for presenting those really remarkable cases. I'm just thinking about how you feel when these patients come in. And just to echo things that have already been said, I think those cases, pretty much everything you showed, with the possible exception of the jumped and perched facets, are very they're difficult cases anywhere, and they're difficult cases for us at a major trauma center. In fact, I would venture to say that there would be at least maybe one or two of those cases that we wouldn't even do, and the deformity is no different. So the other point I wanted to make was that with the incomplete spinal cord injury, I do think that there is quite a bit of opportunity for the patients to have their quality of life preserved and actually even get return of neurologic function, particularly for those thoracolumbar cases, and then certainly for the cervical. But it's very, very, very dependent on the post-op mobilization and rehabilitation. Unfortunately, I've seen too many cases in developing countries where the surgery is done and then the patient for whatever reason, just really cannot get up and mobilize. The services aren't there, the families aren't there, and the kind of knockoff Kinnair bed is broken and hasn't been serviced, and then those patients end up with bed sores / decubiti, and then they get a wound infection, and it actually almost is worse than if they hadn't had surgery at all. So I really appreciate, Mengistu, the fact that you seem to understand that the post-op care, in addition to all of the intra-op care, is just as important, if not more important. And you even mentioned that it's actually more expensive. So that would be my probably pessimistic / cautionary tale. And I would say that actually, I think that the deformity cases should really, those pediatric deformity cases really shouldn't be done in any place other than a deformity center. I think the risk is just too great for those patients. I think if you want to try to send them across the continent to Dr. Bawacha, you could probably do that. That's all I have. I'll put my hand down now.
Yeah, no, those are really that's a really helpful perspective to have. And I'm also curious, Mengistu, for those patients that you currently see who had the spinal cord injuries. I think you mentioned it briefly in your presentation, but can you share with the audience what's their pathway now? You know, what happens to them when they don't get surgery? What services are available? And where do they go after the hospital or and the natural history progression?
Thank you. Regarding to the spinal cord injury case, I mean, we give a big priority for incomplete spinal cord injury, as you all mentioned, because they are the most who get benefited from it. Even, but as we discussed last time, even those patients who have HGOC still, I feel like they are equally benefited like that of the incomplete one. The only difference is the aspiration or the demand for these two group of people. So those who have incomplete spinal cord injury, my aim as a surgeon is just to make them rehabilitate early and return back to their activity, unlike that of the complete one. The aim of surgery for complete spinal cord injury is just to make them, if possible, if their upper extremity is working, for example, for the thoracolumbar, they need to be wheelchair-based, and they will mobilize at least from house to outside, bed to wheelchair and the like. That's a big thing to them, because our community is completely different from the Western. We are living together, but we have some activity to do, and we can't afford to get even the social rehabilitation or somebody to take care of that injured patient. It is not easy thing. It is like having spine injury with HGOC. It is equivalent to do these sentences. It is equivalent for my population for different aspects. Like the family, even they can't take care of him at some point of the, they will get failure. They will get failure. So just if we give some stabilization for them, it will significantly help on the rehabilitation. That's the whole point. Regarding to the pathway, how they go, those patients who get operated, yeah, of course, they will have short follow-up with us. We will see at 2 weeks how is the wound and everything. If there is any new development, either DVT, UTI, or anything, whether they are catheterized or not. So after 6 weeks again, we'll see them and the like. So this is the way we follow. Then 3 months, 6 months, and the like. In between, some cases may need to come more frequently than that of the others. Based on the case, it will be individualized. But those patients who can't afford just even to buy OR material, operation room materials like glove, saline, and the like, we can't do anything, seriously speaking. I know it is shame for me to say it, but we can't do anything. We can't buy everything. For example, we can arrange the implant and the like, but they may not able to pay small payment like for anesthesia medication or the like. Then what will happen? They will go to home. The family will insist actually. On the next day, when we told them like the outcome is like this, the operation would be done like this, and the overall goal of the surgery will be this one, then they will discuss and they will say, no, we should take back to home. So some of them, they will not come back. I never see, for example, some of the patients, I never see at all. They didn't come back. I don't know. They may die, or they may be bedridden in their home, or they may travel to other centers where they get kind of either the same or different kind of service. I'm not aware of this thing, and we don't have any system to track these patients. But in some scenarios, of course, even when they left against medical advice, we'll advise them to come to outpatient clinic in the follow-up. There are some patients who come to us. For example, one of the patients that I present for you, we see most recently, last Tuesday. And her initial neurology was, I mean, the C2C3 bilateral facet dislocation. I'm talking about her. Just 3 weeks back, it was like 2-3. But now, approximately, it is 4 and 4 plus. Luckily, she's getting like improved with her neurology, even though it is not reduced back. So we are getting some patients like this. They will come to our outpatient clinic and we'll proceed with that of the physiotherapy. Again, the physiotherapy is not, it is well organized, or we don't have a central physiotherapy center where we can send the patient. One thing, they came from different areas. The place where they come, they may not have physiotherapy service at all. Even there is no hospital nearby. So that is another difficulty. The other point, they can't afford again to go and do physiotherapy, even in some private centers. So that is another difficult issue. But we'll discuss with the families how the patient should be rehabilitated, and as they should be supported for the patient. So this is what we can do. I don't think it is optimal care that we are giving for the patient. It is really, really suboptimal. But this is what we can do due to the resource and the capacities that we have, Hawwa.
Yeah, no, thanks so much for sharing that. I think that's important kind of thing to understand. How patients, the kind of current standard of care based on the limitations of resources that you currently have. And also, do you mind putting the slides back up? I know you had mentioned a couple of things on your last slide, actually in terms of long-term research. And I think those questions that you had brought up, even with something as straightforward as what we think is straightforward as pedicle screw anatomy, I thought would be interesting to discuss as well. Did anyone else have any questions about those cases? I know we have looks like we have Dr. Rosen on the line. Looks like Dr. Bhatia is on too, about the cases presented.
No questions on my part, but thank you so much. Thanks for letting us be involved as well.
Awesome. Yeah, Mengistu, if you wouldn't mind just talking a little bit more about this, because I think in terms of, you talked about even your second research idea, the pattern outcome of previously managed spine trauma cases, perhaps comparing those who are lucky enough to afford the implants and those, unfortunately, who cannot afford them. I think that would be pretty interesting to look at. Were there any particular outcomes that you were interested in trying to track for those patients?
Yeah, so I mean, we need to follow this patient to have a particular outcome. For example, if we say it will be, first of all, the outcome will be different for operative and non-operative patient, unless we studied like patient-reported outcome measure, like health-related quality of life, either measured by some score or EQ535L. For example, if we look for infection, it will be only for operative cases. So overall is what I want to mention, since the spine services just being started in Ethiopia, at least we need to have the overview of how their outcome look like, the gross outcome. I don't know what that specific outcome. I don't have primary, secondary outcome. We didn't draw still, but we can for prospective study, we can design that one. But it is a kind of retrospective overview of case that we have so far. We have a good documentation on that, on the morning presentation PowerPoint, and there is a Telegram page where every case will be posted there. And I have also the imaging of all patients whenever they came, even including their follow-up. So we can see on that aspect. Since we don't have a lot of cases throughout this 1 year, we can't categorize the case and do a detailed study of the cases. This will be just an overview. Like, for example, how many patients of C-spine? One of the big challenges that I get here, most of the spine case, they will expire in the hospital. They will die in the hospital within 3 to 5 days. They will come. Initially, they will have good vital sign. Just after 24 hours, it will go down. They will transfer to red zone in the emergency OPD, and we will hear the news like they get expired. So these are some things that it is a kind of big issue that we can await to the university, and using the university media, we can disseminate the information. So if people sustain trauma to their neck, for example, their mortality is high. That is one key finding that we observe. Then what is the solution? We need to prevent. Prevention, primordial prevention will be key for such type of cases. That is the points that I have in my mind, for example. So how many patients return back to their activity? That's another important point as well. Specifically, my concern will be on pattern. What type of spine trauma patterns that we are getting in our center? And we need to compare with other studies. Why we have that pattern? For example, we are getting a lot of spine most recently, and all of them, they are fall from tree, either while they collect fruit or while they are cutting tree. Almost all. So this is something that we need to work on that. It is not acceptable. Like somebody, he can take care initially, but due to lack of care, if they fall and having permanent disability or death, it is something to prevent. I feel it is not inevitable. I mean, it is not inevitable. We can work on prevention modality. That's why we are interested to see the pattern. Then what is the common mechanism of injury? Based on the mechanism of injury again, we can alarm the community using different media, and we can also work on the local governors to work on that aspect to prevent fall or other mechanism of injuries. That's what I have in pattern and outcome of previously managed patient. I don't have a clear outcome because our patient is small. For example, we operated nearly 26 patients so far. Just 26 patients alone from 100 plus patients. So most of the patients, they are not managed. And it is difficult to do comparative study with the same, for example, those patients who need operative treatment. It's a thoracolumbar, operative versus non-operative. I can't do. The number of patients that I have is really small. It is it will be case series. That is the thing. So just for the local consumption, even though it is not for the national communities, for the local consumption, we can design a kind of brief scoping type of case review. Then based on that, we can work on the prevention modality.
Okay, then that's super interesting. I think it would be a really important topic as well. And to your best estimate, what percentage of patients that come in with operative spine cases actually get surgery? Are we looking at 5%, 10%, 20%?
I should say not more than 10%, nearly 10%.
Yeah, so only one in every 10 patients get that. So I think
Maybe.
that's yeah.
Exactly.
If that, and then you're saying that these cases that you have, and you mentioned something about having the spinal cord trauma cases that you presented earlier. Even though they were not able to afford surgery, you still see them in clinic to get physical therapy. Is that correct? So is that a separate clinic that's run at your hospital? Do they have to go elsewhere for that PT?
Tuesday we have clinics. This is dedicated for spine cases, operated spine case, non-operated, degenerative, and every spine case will come on Tuesday for the whole day. Then we'll see, and if they need to be linked to our own university physiotherapists, we have a center in the same compound nearby to our clinic. Then we'll send the patient to physiotherapy. Those patients who, or the families, if they say, no, we can't do physiotherapy here because we came from another place, like 150 kilometers or something, or 200 kilometers away, then we will write on paper as they need a specific type of physiotherapy, like strength exercise or quadricep strengthening or something. We'll write that one, then we'll give to the patient. They will take the paper to nearby center where they can get the physiotherapy. But as I told you, most of the patients, they came from a rural area. They will not have a physiotherapy center. That is a big challenge. Otherwise, those patients who can do PT in our institution, yes, we will just link them and they will do there. Then once they link to the PT, it will be all about the patient or patient family and physiotherapist discussion. For example, how many times per week they need to do, for how long they will need to do, and the like. It will be based on the patient response, the patient ability to come, and the number of patients that the PT has. So it will be like that one. We can link to our own institution, or we can link them to outside.
Is there any current registry, Mengistu, that you have for these patients, or do they get tracked in any way now when they come in for initial presentation?
So you mean a kind of registry? What kind of registries?
Basically, like you could make a few different registries based on the pathology. One of the easiest might be just the trauma registry. So you just document the patient's type of injury, type of neurologic examination, and then we can follow them if they even have the ability to, let's say, follow up in clinic. You mentioned the patients that even leave AMA, they're given the advice that please follow up in our outpatient clinic and see how much we can help you regardless of whether you have operative care.
Yes, so we have registry actually, musculoskeletal fracture registry. Previously, we used to have a WHO trauma registry, which include all patients, all trauma patients. So later on, we develop our own registry, which is a web-based registry. So there is one MPH candidate who will be there for the whole clinic day, Monday to Friday, and collect all the trauma data, including the spine patient data. So those patients who visit our outpatient clinic will be captured with that registry. It is a web-based registry actually. So we can do that one. And all patients who pass through the emergency OPD will also be captured.
And any patient-reported outcomes that are captured in the registry now? Or is it all of the objective data?
So the current registry, it has 3 months, 6 months, and 1 year outcome measure. Then the patient will be discharged from the registry. The registry will be in at 1 year follow-up. So it has, but it is not specific to the spine. It will be a general outcome measure and general complication assessment, like presence of infection, presence of DVT, and we are using that is what is validated in our center, just to assess the quality of life of the patient. Otherwise, we don't have, like, for example, AO spine, functional outcome measure. We don't have that one. The registry is meant for all musculoskeletal trauma.
Well, thanks so much. That brings us to the top of the hour. Does anyone else have any questions or comments?
Thanks again, Mengistu.
Thank you.
Yeah, thank you so much, everyone. I think we'll also try to make this recording available on YouTube. But thank you.
Thank you very much.
Keep up the fight, Mengistu. Good job.
Thank you very much. Thank you.
All right. Thanks, everyone.
Thank you.